Thank you very much, Professor Kalvach. As you have seen, this is the title. We're going to talk about problems that existed last century. There were some solutions found, surgical solutions last century. There were some refinements made this century, and you, the young generation, will find maybe a smarter solution in the future. So basically, instabilities of normal motion that causes pain, neurological symptoms, deformity risk, and surgery is planned when conservative treatment fails, of course, to decompress nervous system and to correct deformities. Instability caused by trauma, by tumors, osteolytic metastasis, for instance, also by some infections, is easier to understand than the degenerative disc disease, but I'm going to try to explain you what is all behind. So we'll talk about anatomy and basic neurology, then diagnostic imaging, and see post-traumatic cases, and then degenerative lumbar cases. You know the spine with cervical lordosis, 7 cervical vertebrae, 12 thoracic or dorsal vertebrae, 5 lumbar vertebrae, and the curves, the lordosis important, cervical and lumbar. And if you see in blue the 3-column definition by René Louis, you have the anterior column, which consists of, of vertebra, disc, and so on. And you have 2 posterior columns. These are the articular processes on left and right side. So lordosis, kyphosis, lordosis, and then the sacrum is fused. And this spinal column contains the spinal cord, the exiting nerve roots, and at the end, the coda equina. So the, wait a second, this new thing. Okay. This is the spinal cord. It ends at L1, L2, and the peripheral nerves go out on every level. And distal to the end of the spinal cord, which is central nervous system, you have the roots of the coda equina, which gets together and forms, example given here, the sciatic nerve. The peripheral nerves. When you have a lesion, it depends on the level, how much will be compromised from the neurological function. Here up in the cervical spine, you have the cord, the exiting nerve roots, and you have CSFs, cerebrospinal fluid, very important, around, as isolating and protecting fluid layer around the central nervous system here. And down, you have the coda equina with the exiting nerve roots. This is peripheral nervous system. So if peripherally a nerve is compressed, it's a peripheral nerve compression. And if the cord is compression, it causes myelopathy, which has got some more damage and functional impairment. When you look at the anatomy, allez, zut. Probably it's easier to work with this one. The pedicle is essential. You have the vertebral body here, the disc, the vertebral body, that's the anterior column, and then you have the pedicle. And the pedicle, on the pedicle are the posterior elements with the articular processes, transverse process, lamina, and spinous process. Important is that through the pedicle, you can put screws to stabilize the spine. You can go through the pedicle to inject cement. If you have an osteoporotic collapse of the vertebra, you can percutaneously treat it by injecting cement and giving back the height to this collapsed vertebra. The zones, intraforaminal is the zone between the pedicles, and j'ai un problème là. This modern one should, voila. Foraminal zone is here between the pedicle. The foramen is where the nerve root exits. And you have the extraforaminal zone, and here the intracannular zone. Defining stability. You have the definition of René Louis. Very nice to see that you have an anterior column with vertebral body, disc, vertebral body, and so on. And this carries 80% of the loads in the healthy human being. With degeneration of the disc, the load is transmitted posteriorly, and then you have degeneration of the facet joints, spondyloarthrosis, and so on. When the disc collapses, you will have foraminal narrowing. For the stability, anterior column and two posterior columns, the articular joints, they work as rotatory brake. Now, basic frequent pathology are disc herniations causing radicular signs. In the lumbar spine, you'll have a radicular compression, an example given from L5, and the patient has got pain. He will avoid some positions, and he will have, when it's relevant, he will have neurological deficits. That means the nerve stops functioning, and you will have a paresis, a sensitive deficit, a reflex deficit. If it's happening in the cervical spine, you will have myelopathy, which is more severe. So let's go to the anatomy. Basically here, the dermatomas of the cervical spine to the hands, then the dermatomas thoracic, important mammilla is Th4, umbilicus is Th10, and inguina is where Th12 and L1 meet. And then here, the genital, anogenital region, which is important for continence, is sacrally innerved. Okay, disc herniation may call a radicular syndrome, where you lose a reflex. For L4, the patellar reflex. For S1, the ankle reflex. But then, if it increases, you will lose motor function. S1 deficit, you won't be anymore a prima ballerina. S1 prima ballerina, you cannot stand on tiptoe because there's a weakness of these extensors. And you see here a basic example of a large disc herniation. If it takes half the part of the canal, you may have a hemicauda syndrome. Radiculopathy in the cervical spine. This is a disc herniation causing a nerve entrapment, like you can see here. Pain irradiating to the arm with sensory trouble, with motor trouble. And then you have the one where the cord is compressed. It's a narrow canal, and you see two high density points, snake eye sign. It means this cord is suffering and is becoming ischemic and having here some edema. Here you see you have CSF around the cord, very important. This disc herniation causes radiculopathy. This one causes myelopathy. And for you, for the next examination for the cervical spine, C5. You make like that. You make an auto-congratulation. C5, the dermatoma is here, and you activate the deltoid muscle. C6, in my time, students like to travel by autostop, so they would go to the road and see if someone would take please free ride on the automobile from Basel to Zurich, or maybe from Prague to Pilsen, I don't know. C6, biceps and sensitivity of the thumb. Victory, C7, politicians, when they are elected, it's biceps, it's extension. the extensors and the sensibility of the index and mid finger. And then the little finger told me that the difference between tetraplegic and paraplegic is a tetraplegic patient, when you come to accident place, he cannot squeeze the hand. C8, innervation also for squeezing the hands. That's the important thing to know. C5, C6, C7, C8, that the tetraplegic cannot squeeze hands. For the examination, for you, it may be relevant. Okay, and then partial lesion like this central cord syndrome. When you have a myelopathy and the central cord is touched, the crossing sensory fibers for temperature and pain are disturbed. So you will have what the French calls syndrome suspendu. It's a hanged up syndrome. That means here you have dysesthesia, paresthesia, hypoesthesia, and some weakness maybe if it goes more laterally. You may have long tract signs like pyramidal signs when it affects the pyramidal tract. And the maximum of a myelopathy, the maximum is in case of cord transection, when you have a severe accident and the patient loses the function below the lesion, TH12 here, dislocation, fracture dislocation with torn ligaments, and here the cord is transection. This is worst case with paraplegia and incontinence impotence. Diagnostic imaging, we go to radiographs. I show you CT scan, MRI, and we'll see some examples of dynamic imaging. When you want to see the spinal cord, the nerves, the soft tissue, MRI is the best, but the normal radiographs have still some value to show you structural anomalies, transitional anomalies. They show the curves. You can assess the lordosis, the kyphosis, the lordosis, and the alignment and measure angles. Then you have a situation with leg asymmetry, a shorter leg on one side. You're walking asymmetrically, and this may trigger the development of disc problems. Transitional anomalies. Normally, you have 5 lumbar vertebrae. You can count. You can count here. You go from the ribs. 1, 2, 3, 4, 5. But here, this vertebrae looks like a lumbar vertebrae. Is the S1 vertebrae, that is lumbarization of S1. You have 6 vertebrae. It's an anomaly, but that may happen. And on the other hand, you can have a sacralization of L5. This L5 vertebra is fused to the sacrum. The first mobile disc is L4, L5. You have asymmetrical ones where you can see that you have a large transverse process touching the sacrum. Sometimes this can cause pain. And it's important when you're going to operate on a spine to know which segment you're going to operate. You must identify the right level. So it's important to know about these transitional anomalies. On the next picture, I show you a case who was operated for a metastasis. Here was a vertebral body metastasis that had to be removed by an anterior approach. You see here the marks in the cage. It's a corpus replacement cage filled with bone. You see screws in C4, screws in C6. This is C5, C4, C3, C2. What you can notice here, you have no articulation because between C2 and C3, you have no disc. The first disc is therefore C3, C4. If you operate on a cervical spine and you localize the level and you don't realize this, you may operate instead of a disc herniation C5, 6 on C6, 7. It's a wrong operation, wrong level, and maybe the lawyer will come and sue you. Next one is to show you the unilateral disc collapse. This patient had a facetectomy. The joints are removed. twice disc material was removed, and it resulted in such a degenerative scoliosis. Then leg asymmetry, a shorter leg here after a fracture, that can make the patient walks in a asymmetrical way, and that stresses the vertebral column. Dynamic X-rays. Now, in degenerative spine, important to see, do you have an increased motion? In traumatic spine, don't move the patient before you have set the diagnosis and see if something is broken or displaced. So, okay, you see here collapsed vertebra. You see here osteophytes. That means that nature with time ossifies and restabilizes the spine. Here, no disc, you see bone. It's a spontaneous fusion L2, L3, which doesn't move. And the question is the level L4, L5 unstable or not? You have the posterior wall. No, it's aligned. You don't have here an instability on this functional imaging of L4, L5, which we have to look at in this case. What you see as well is aortic calcification. So sometimes there are spinal stenosis and vascular narrowing that causes intermittent claudication. Here to show you a classical one. This is unstable. This is over ½ centimeter of motion in the between extension and flexion. And you see here opens a gap. You have here spondylolysis, isthmic lysis. That means the two posterior columns are interrupted here. Spondylolisthesis, the true lytic spondylolisthesis, two posterior columns are disrupting, and here it's becoming unstable. The term pseudospondylolisthesis is used in degenerative disc disease, where there's some listhesis but without lysis. CT scan, do you already know these examination methods? CT scan, radiology, the small tunnel. An MRI with magnetic fields, radio waves, it's without radio exposition. It's the long and noisy tunnel. In a spine, what can you see in a lumbar spine? Here you see the example of the CT scan. CT scan, very precise for bony anatomy, shows the size of the canal. Normally it's a delta form, the spinal canal. But here you have a calcification that narrows the spinal canal. It's a calcified ligamentum flavum cyst, and here you have a narrow lateral recess. This patient may suffer from a L5 nerve, who is here stenotic, is compressed chronically in the lateral recess. MRI shows very well the soft tissue. Here you see a large disc extrusion that migrates downwards. And you see what is important also, where is space? This canal is not narrow. Here you see CSF. Low down you see some CSF, but here it's critical narrow. This may be also a patient with hemicarda syndrome. MRI is contraindicated if you have metal inside, if you have a pacemaker. For the moment, you shouldn't undergo MRI scans. Myelography is old-fashioned. Some countries don't reimburse myelography. It said it's obsolete. You do functional X-rays and MRI, and that's enough. However, it may still be useful. Myelography is invasive. It's a lumbar puncture. You inject contrast medium, and you make a picture not only recumbent, but upright flexion, upright extension. You may do oblique views, and then you put the patient at bed rest for a day maybe to prevent post-lumbar puncture headaches. That's the other smart way with a tilting table. That's what it looks like. Myelography, here you have the thecal sac filled with contrast medium. And you see there is some antilisthesis here, but you see the contrast medium goes down. It goes up and down. It's not totally interrupted. The other case, this is a total stop. This is a stenosis where, with instability, where you have some translation of a ½ centimeter, and the liquid, the CSF with contrast medium doesn't circulate. That's a severe stenosis. Then, when you've done that, add postmyelographic CT scan. A CT scan here, thecal sac well filled with TSF, the nerve root. This nerve root is missing because it doesn't feel it was already operated. You have some little scarring. And I show this picture to show you this part of the bone where the inferior, the superior facet of S1 goes up and blocks the inferior facet of L5. That means here this bone works as a rotatory brake. It prevents extreme rotation. Postmyelographic CT scan show you also a central osteophyte or a medially calcified disc herniation, compressing this cord. It's a narrowing, and this is a myelopathy case from the last century, diagnosed with postmyelographic CT scan. Here you see you can do reconstructions as well with a CT scan. Now we go to the in medias res, the vertebral trauma. You want to see if there is a fracture, if there is dislocation. If you come to accident site, patient is comatose, you must be very carefully not to make excessive movement and risk that the patient who may have minimal damage gets a heavy neurological damage because an unstable fracture was displaced by manipulation. Then neurology, if the patient is awakened on accident site, and you have to see if it's a stable situation or a deteriorating patient, emergency examination, imaging, and probably surgery. Okay, do you know what is GCS on accident site? What do you check? Glasgow Coma Scale. Is the patient conscious? Very important, GCS, Glasgow Coma Scale. You see if the patient has eye open, if he opened the eyes when you call him, or when you apply some pressure on him, or if he never opens the eye. And then is the verbal answer, does he speak, or is he disorientated, or is he maybe going to be comatose? And then the motor, does he move when you say, please move your foot, move your hand? Is he able to obey commands? Or has he got, when you apply some pinching, just a retraction? Or does he show extensor spasm, which is very bad sign that the brain stem in a heavy injury is suffering? So Glasgow Coma Scale, pain location, motricity paralysis, and sensory level, that's what you do on the accident site if you arrive as emergency doctor. Classification of spinal fracture, I briefly say, they started in 1994 with 5 authors. Some other authors from USA made modifications, and then colleagues added, so it goes to 32 authors. And I think imperfection is impossible. Classification may be useful, but it's important to know that, to be able to go according to some protocols, but you must evaluate your patient individually, and the surgical decision is always focused on the individual patient. So train your visual spatial centers, evaluate diagnostic imaging pictures, and the classification may help you to decide when to operate or which case to operate. Basically, AO classification, A is compression, so the A inverse like that. B is distraction, here you pull, and C is with rotation. A, B, C is the more heavy injury type. Here you see a rotation injury as a drawing, fracture, and a rotation. And if it is affecting several levels with transverse process which are broken, then this patient will need a long fixation. This is an example. You see when you look at the spinous processes, and here you have the fracture, the dislocation. Spinous processes row is here. And on CT scan, you see that you have a rotation and a dislocation. This is a severe type with paraplegia. It was initially easy to understand the AO classification. Does it really reflect what's happening during an injury? Okay, yeah. Compression, rotation, distraction. You see, it's not, does it repeat? Yes, a second time, look here. Whoops, puff, compression, rotation now, and distraction. And again, compression. So classification are useful, but they don't show everything. Okay, thank you very much for the help. The next classification adds the analysis of posterior ligament complex integrity and the neurological status. That is important. It's a point system. So you're getting points. The more damage, the more points. The more you have a disruption, the more points. And the more you have neurological problems, the more points you add. So you see, you can examine the compression fracture, extension fracture, distraction, but the important is to know is posterior ligament complex, supraspinous, interspinous ligaments, joint capsule ligamentum flavum, posterior longitudinal ligament, is this disrupted or not? Okay. Here you see the example, you score with points. And with neurology, you have more points. And with posterior ligament disruption, you have more points. If you have just compression fracture, and this is okay, then this may be treated conservatively. But this rotation injury with disruption will need surgery. So do you know maybe Agatha Christie, Master Detective Hercule Poirot? He would say classification are useful for teaching, training, evaluating, and comparing treatments, but they don't show everything. Perfection is not reached. Possibly added value, how can we prove it? Because every accident and every patient, when you have to operate on a patient, you make informed consent. It's an individual decision. You must understand the problem and treat the patient adequately. Now, basically, what can we do? Dick, Walter Dick from Basel, Switzerland, made pioneering work with the internal fixator. You see here a fracture. You insert pedicle screws left and right. Above and below, you put some rods, and then you do some lordosing and distraction. And you're hoping the posterior ligament is intact. And that will help that with this distraction or relordosing, you can reestablish vertebral body height. Unfortunately, there are some failures. You see here, this is a vertebra compressed. You have a kyphosis. You put Dick internal fixator. The vertebral height is again quite okay. Also, the kyphosis is diminished. It looks nice. It's just a principle. Dick internal fixator. Now, another case. Here you can see clearly there's a fracture of a screw. Now, why do spondylogenesis fail? Why are there some screw breakage and so on? What do you think? Who thinks, A, it is because the operation was performed without robotics? Who thinks operation was not planned with artificial intelligence, that's why it failed? Who thinks ferromagnetic implants, well, these old screws are too old and MRI is not possible, it's not a good technique? Who thinks that it is maybe due to insufficient load sharing, a weak anterior column? Yes, yes, well, you're right. Your colleagues had also raised their hands. It's not because we have no intraoperative monitoring or no navigation. It's just basic, of course. This is modern robotic suit where you will have intraoperative imaging. You have the operative table, the patient can be put under it. you have this location system for the match with the CT or MRI, the pictures, and then here on the Congress, you can practice, you see, you can practice on a plastic model and see how you would put the screws. This is that helps. You see, the important thing is that you introduce the pedicle screws at the right place, that you go into the vertebra, and that you don't go and hurt the nerve. When you insert a screw, you shouldn't insert it where the nerve passes. You shouldn't go into the spinal canal, into the lateral recess. So this technology helps. Yes, it is good. But the problem was the anterior column was too weak. The scoring system shows the more is crushed, the more points. The more the fracture fragments are displaced, the more points. And then the kyphotic deformity of a compressed fracture, the more points. And the experience has shown that over 7 points, there is a risk of posterior instrumental failure if you don't support the anterior column. Okay, instrumental failure means a screw, rod, or plate may break, and it's generally due to insufficient load sharing within the anterior column. So you analyze comminution, dislocation of the vertebral fragments and the kyphosis of the vertebral body. And this was a case where anteriorly it was too weak and it didn't hold. So again, repeat, the kyphotic angle here is a major one, 3 points. Huh? And the comminution is also 3 points. And the dislocation of the fragments is not shown here, but the result of an immediate postoperative radiograph is excellent. Then 6 months later, you may see that it collapses again. And these screws are a little bit suboptimally placed. They're eroding in due time the vertebral end plate. And so there are different possibilities. And this is to use such a distractable corpus replacement cage in order to realign and reinforce the anterior column. Anterior column, I just make a bracket and say that we have cases with vertebral fractures due to osteoporosis. And when it's an osteoporotic crush, collapse of the vertebral body with pain, then the option to inject cement, do a kyphoplasty by adding a balloon and a stent is a real option for optimal treatment in these cases of painful compression fractures affecting the anterior column. That's the message for you. Here you have a missing bony element. That's to summarize, no bone, no solidity, unstable. Again, this extreme case with fracture dislocation with cord transection, and here the operation is done, the spinal fixation for stabilization and reconstruction, realigning the vertebral column. It allows earlier mobilization and rehabilitation. Another one, I want to point at the arrow. You see, as a vertebral split fracture, and there's been a fragment displacement over 2 millimeters and a crush, big comminution. And when you have here disc material and here disc material, if this disc material goes in the fragment between this bone won't heal. There won't be a consolidation. And so the best technique is then to really address the problem with a posterior instrumentation and then add anterior instrumentation. This is major spinal surgery done in big centers. Again, I have to press on the button, but probably it doesn't work. It should be sound just to relax, just to... Okay, we skipped it and play it later on. Okay, let's go to the next one. I talk about the degenerative instability, degenerative disc disease, and degenerative instability. Three phases in the life: dysfunction when the disc gets older, then instability where motion causes pain, sometimes neurological signs, and then comes the stage of restabilization. In the first phase, you have conservative treatment. When there is disc herniation and disc herniation plus instability, you may add surgery in selected cases. Sometimes just wait and see, as nature may heal, restabilization with calcification, ossification, but sometimes excessive ossification may lead to spinal stenotic. So you're young, healthy, and fit. Old, you may be old and narrow and calcified. So also in the old age, you may need a decompression, microsurgical decompression for stenosis. You all are young and healthy, your disc ligaments and muscles are fit, you have a good motion and a good spinal stability. Don't worry, be happy. But, however, when you get old, degeneration will occur and you'll be prone to problems. Here you see the picture. If you take an X-ray of such an athlete, you may have some retrolisthesis on many levels, but it's not instability. This one is elastic. He gets back in the neutral position. He's pain-free. It's called hypermobility. So if you do X-rays, just see if you have clinic, if the patient has, if you have a sportsman who can do that, and you make an X-ray and it moves a lot, it's not unstable, you have no clinics. So to speak about disc degeneration, the disc starts with fissuration, you have clefts, you have these tears. Annular tears, when they occur, can make backache, lumbago. And you have also the possibility that that through the tears, from the degenerated nucleus, some interleukins, tumor necrosis factor alpha, some chemicals go out and irritate the nerve chemically. This is an old example of a discography. They've been injecting the disc. This disc is continent, is okay. But this one, the contrast medium goes out. If you do a post-discography CT scan, you see contrast medium here. It may hurt the nerve. Discography has been abandoned as you have a little risk of infection and you have a little risk to start degeneration of disc by injecting a hurting disc, which is okay. MRI again, pointing at that, disc height loss, disc herniation, kyphosis instead of lordosis. It's the start of degenerative problems. Now, speaking about instability, you want to detect increased abnormal motion, and you are going to assess on motion X-rays along an axis and around an axis. So you see vertically, y-axis, when you have a large disc herniation, you lose a lot of disc material. You may have some kind of vertical instability that causes pain. And then when you do facetectomy and repeated discectomy, you can also have the problem of rotational instability if you hurt or take too much away from a joint, and the intervertebral joint doesn't act as rotatory brake. We had something interesting in Zurich. It is the upright MRI technology. It's an open MRI where you can examine the patient in upright, standing, or sitting position, bend it forward or backward. Randy Jenkins, neuroradiologist from San Antonio, Texas, co-author and author of some books with me, Jean-Pierre Helzig, who wrote chapters, who installed this machine, was pioneering this technology. Now, we saw already here instability over 0.5 centimeter of slip. Here it's due to a spondylolysis. You see a myelogram, also the 0.5 centimeter displacement and the total stop. This is with invasive lumbar puncture and contrast medium. This is just a plain X-ray. And what do we see with MRI? Now, this dynamic MRI, you see some antilisthesis of L4 on S1, or L4 on L5. You look at the spinal canal and you see white liquid CSF. It's very good. You need to see CSF here, maybe a little more. Maybe there could be a stenosis, but do we really know with only a recumbence image or in a flexion image? You need to go on. And when you do an upright extension MRI, where the patient is loading, where you have the body weight on these segments, you see that there is a dynamic stenosis on 2 levels. CSF here, and bulging of the disc, the ligament flava. Here, CSF, okay, but here it is stenotic. And the next one shows axial. That in extension, you have this bulging of ligament flava, lateral recess stenosis, and another detail, fluid. If you see fluid in the joints, it's an indicator of reduced stability. And by the way, maybe interspinous, there's also a little bit fluid here. We call it morbus Bastrup interspinous arthrosis. We go to another case to tell you about the intervertebral fusion cages. Intervertebral fusion cages, when you empty the disc at disc herniation operation, why leave this hole open? Put something inside to stabilize. This was the philosophy of the disc cages that came up in the 90s of last century. Check this level. Degenerated disc, it's black. Disc herniation. And here it's edema in the end plates, irritation on the end plates of this segment. And this case was treated with a disc cage, left and right, low dosing, and you have gain of height, restoration of some lordosis with this simple technology, microsurgical spondylodesis with no vertebral fusion cages. It's not suitable for every case. We have 3 pathologies on one level. You see here CSF. The cord stops here at L1, L2. Cordaquina fibers. Here it is stenotic. And axial view, CT scan, shows that here it is black. You have no CSF in the spinal canal. Dynamic X-ray shows you that it is mobile, that you have instability, radiological instability. And then you can choose. There were many types of cages, 1999, when we wrote this first monography, to stabilize the spine, the anterior column. And here we put this this Varilift cage. It is one which you can screw and augment the lordotic effect of this Varilift cage. And so with 2 Varilift cage, we could restore disc height and restore lordosis. And this is the book 2002 with Randy Jenkins as co-editor. Why cages? The philosophy is here you have the loads. When you're loading a degenerated disc, it may cause pain. It will lead to arthrosis of the posterior elements as more load is transferred to the posterior facets. And then if you do a spondylodesis like that and the disc is almost empty, you have also vacuum sign in the disc indicating heavy degeneration. It may have also a failure in degenerative surgery. So disc cage was this idea. It's a container, it's stabilizing, and it contains bone, and this bone will grow through and achieve a solid fusion. And this is a 360-degree fusion. you could use in the old century some bone grafts, today rather cages, and this is the most solid fixation. So cages after discectomy are mechanically stabilizing. They are biological spongiosa container. They lead to the intervertebral fusion. Again, the weakness after large disc herniation or recurrent herniations, disc extrusion, weakening of the anterior column, weakening of anterior column, and then you insert cages filled with bone from the iliac crest to restore some lordosis to stabilize the segment. This standalone surgery is for restricted indications. Generally, orthopedics have set the standards that you should stabilize 360 degrees with additional posterior instrumentation. Well, up to now, everything clear? We have here a case. This is an MRI of a patient who had undergone a laminectomy and fusion, L4 to S1. So L4 to S1 here was decompressed and fused. And because the patient had some back pain, oh, can you remove this implant? Okay, it was removed. And what happened then? On this image, you wouldn't reoperate on the patient. So you put him into upright MRI, and what you see here, evident hypermobility, antelisthesis above, and stenosis here when it slips. So the problem is that this is an adjacent segment disease. It was already pointed out at the Discage meeting in '97 by John Brantigan, and I did this drawing for the book. If you do a straight fusion instead of lordosis, the upper segment will try to compensate and will rather go into retrolisthesis. And there are cases where you do big surgery in order to restore a proper lordosis, a proper balance to the spine. So adjacent segment disease means above or below a rigid fusion, there is accelerated degeneration of this neighbor segment. Again, a problem, and maybe again a case who will need surgery. You see here it was in 2018, an operation to fuse L4, L5, S1. And in 2019, stenosis L4, L3, L4 developed and became symptomatic. You see the contrast medium here, 3, 4. Here, it's bulging here, it's slimmer, and in retroflexion, the contrast medium doesn't go through. So this is a myelographic stop, and here no filling of the thecal sac here behind. So this is adjacent segment disease. So the Randy Jenkins, ambassador of the upright MRI technology, says yes, in some cases who cannot undergo MRI because of pacemakers and so on, this old technique of myelography may be useful. If you can use upright MRI, if it is titanium screws, titanium rods, you can make an MRI to diagnose adjacent segment disease, which is a problem that can continue to lead to further surgeries in the future. We have, I think time is over. This was the European course in neurology at Stares Plavny. Professor Kalbach organized that. I was there with my band in 2010, 2013, and 2015. This was in Burgundy, and here at the Doctor's Ball with the colleagues dedicating the placard, comment on dit, for the concert. We have a CD, www.rollin50s.ch. You can listen some things there. And this CD, I don't know, maybe the faculty can take it and put my compositions somewhere that can download it if you're interested. Now I'm open for questions.